All right, guys, I had a few of you guys request that I record these slides at the end of part one for the head so that you guys can get started studying on it right away instead of pushing it off closer to the exam. So here you go. Okay, so these next few slides are just showing you guys the dural venous sinuses. They're just like veins, right? They're like really big, kind of sac-like veins that are present in the head that collect deoxygenated or oxygen-poor blood from the brain and bring that back down to the internal jugular veins to go through the rest of circulation. We call them dural venous sinuses because the majority of them are located in the dural folds. Remember, the dural folds are like where the dura mater goes in and folds down in towards the brain and then keeps going. So we have these like venous, cavities or sinuses that are located in those dural folds. And you see them all here in blue. So, it's the same picture on every slide, but I highlight different ones on each slide so that it's easier to look at them instead of looking at all of them at once. On this slide, we'll look at the superior sagittal sinus and the inferior sagittal sinus and the straight sinus. I have them starred. So the superior sagittal sinus is the largest of the dural venous sinuses. It goes all the way like this. Okay, so superior sagittal sinus. The superior sagittal sinus goes along the top of the falx cerebri. The falx cerebri, that's the dural fold that goes down between the cerebral hemispheres. So this is going down in the longitudinal fissure, right? The fissure that's between the two cerebral hemispheres, so down the center of the brain. And this is going down all the way from the crista galli in the front back to the internal occipital protuberance, right? The little part that protrudes from the occipital bone in the back. Where this comes back here, where this meets up with all these other sinuses, that's called the confluence of sinuses. Confluence. It's E-N-C-E, confluence of sinuses, because there's a bunch of sinuses that come together right at that point. So that's the superior sagittal sinus. The inferior sagittal sinus is inferior to that. It still goes along the sagittal plane, but it's right here, and it goes along the bottom of the falx cerebri. So it drains blood inferior to the falx cerebri, the fold that goes down the longitudinal fissure. Where is it labeled? Here. The inferior sagittal sinus goes back. It doesn't go all the way back into the confluence of sinuses, though. It goes back to something called the straight sinus, and it's straight. So when you look here, that straight sinus is draining back towards the confluence of sinuses, so back towards the back of the brain. The straight sinus is going as it runs posteriorly, as it runs towards the back. It's running along the tentorium cerebelli. Remember, the tentorium cerebelli is the cerebral fold that goes between the cerebrum and the cerebellum, right? So there's this, it kind of goes up like that. Sorry, it goes up like this, and the cerebrum is up here, the cerebellum is back here. So it's straight right along that tentorium cerebelli. And then again, it goes back towards the confluence of sinuses. So the transverse sinus, so there's actually two, there's one on each side, but the transverse sinus comes around the lateral edge of the tentorium cerebelli, right? Again, that dural fold that goes in between the cerebrum and the cerebellum. The straight sinus comes down along it, and then the transverse sinus wraps around the edges or the lateral aspects. So you see there's also one over here, another transverse sinus over here. The transverse sinus comes around the lateral edge and it flows into the sigmoid sinus. The sigmoid sinus is like S-shaped, right, like that. Just like think of the sigmoid colon, right? I always think S for sigmoid, right? The sigmoid colon is like S-shaped. The sigmoid sinus is like S-shaped. And that sigmoid sinus flows down into the internal jugular vein, right? So we said that all of these are ultimately going to be flowing into the internal jugular vein. So most of this blood leaving the brain goes down through the internal jugular vein. So the sigmoid sinus, as soon as it exits through the jugular foramen, remember when you look at the skull, like when you take the skull and you flip it upside down, and remember we see like the foramen magnum, the carotid canal, foramen, jugular foramen, foramen ovale, all of the little foramen that are present underneath the skull or on the inferior side of the skull. One of those major foramen that we look at is the jugular foramen, right? So as this sigmoid sinus goes through the jugular foramen, it exits the skull as the internal jugular vein. So we've got a few more on this slide. The occipital sinus, which you see right here. The occipital sinus lies along the falx cerebelli. The falx cerebelli, remember, goes partially in between the cerebellar hemispheres, right? So the cerebellum is like back here, and the falx cerebelli goes in between the two halves of the cerebellum. So the occipital sinus is back here, right, like the back of the skull. Also, we have a cavernous sinus, or actually there's two of them again. So here you see the cavernous sinus here, and then on the other side there's another cavernous sinus. They're these like kind of really wide, broad, circular shaped ones. They lie on either side of the sella turcica. So they lie on either side of the pituitary gland, right? So like the sella turcica, remember, is that like little depression like this, and the pituitary gland hangs down in it. On either side of that, there's a cavernous sinus. They do communicate with each other via intercavernous sinuses. You can't really see it on here, but so there's like a cavernous sinus on either side, and then there are these little vessels that go back and forth between the two that are called intercavernous sinuses. These cavernous sinuses drain via the petrosal sinuses. So you see superior petrosal sinuses and inferior petrosal sinuses. So going back, again, the cavernous sinus is this kind of like circular shaped one, and then the superior superior petrosal sinus, and then the inferior petrosal sinus. And they're just draining down towards the like the transverse sinus and then into the sigmoid sinus. And the inferior, of course, is going directly into the sigmoid sinus. Okay, so this is how we drain oxygen-poor blood from the brain and down into the internal jugular vein. Here you guys can see the arteries that feed the dura, right? The actual like dura mater, as well as the calvaria, right? The bone, the calvaria. The blood that's feeding the dura and the calvaria is from the external carotid artery. The brain itself is getting fed from the internal carotid artery and the vertebral arteries as well. So the vertebral arteries and the internal carotid arteries are giving blood to the actual brain itself. But the external carotid artery does deliver blood to the dura and the calvaria, the bone. And here you can see that. So the external carotid artery is right here, right? You would have the common carotid artery, and then, and then right about the jawline, it splits. And we have the internal carotid artery and the external carotid artery. So that's the external carotid artery in the bottom. The maxillary artery is this second arrow. So like right there would be the maxillary artery. The maxillary artery gives way to the middle meningeal artery, which is the one, like the third arrow, that's kind of heading up. So the middle meningeal artery comes up like this. And then the middle meningeal artery is going to split into a frontal branch and a parietal branch. So the frontal branch you see right here, and then the parietal branch goes back towards the parietal bone, the parietal region. And then of course those continue to divide as they go out towards the, as they go out, superficially. There is sensory innervation to the dura. So like when there's inflammation present in the area, we do sense that there is sensory fibers that are coming from the dura. Now the dura is innervated mostly by cranial nerve 5, right, the trigeminal nerve. Which you guys know has 3 branches, right? V1, V2, V3, which those 3 branches are the ophthalmic, maxillary, and mandibular. So like 3 branches, right? If you just kind of put the 3 like this, V1 is up towards your eyes, so ophthalmic nerve. V2 goes over your maxilla, right? Your upper jaw. Sorry, I just like flicked, I didn't mean to flick you guys off. Goes over your maxilla, right? So that's V2, maxillary nerve. And then V3 is down here over the mandible or the lower jaw. So V3 is the mandibular nerve. You can see down here this kind of purple region down here. That is, those sensory fibers are carried by cervical nerves, but everything else that you see is via the trigeminal nerve. Most notably V1, which is the ophthalmic nerve. All of this like light green that you see, all of that is served by fibers of the ophthalmic nerve. And you can see mandibular is over here in this like darker color, and then maxillary is in this kind of pink color. But again, you can just say the cervical nerves via the inferior parts, the superior and lateral parts are all via the trigeminal nerve. Here you guys can see the cavernous sinus. Remember we said that the cavernous sinus is the area on either side of where the pituitary gland sits in the sella turcica, right? So there's like this little depression. This is the sella turcica, or we call this the hypophyseal fossa because that's where the hypophysis sits, right? The pituitary gland. So you can see that down here. Right, this is the fossa, and then you can see the pituitary gland sitting in it. Right, the infundibulum is the little stalk that connects it to the hypothalamus. But we said that the cavernous sinus is one of the dural sinuses, so one of the areas where we've got a lot of oxygen poor blood draining from the brain. So you can see on either side of the pituitary gland, right? So like this is the dural sinus. That over here is the dural sinus. There are quite a few important structures that pass through the, I'm saying dural sinus, the cavernous sinus. There are a couple important structures, or quite a few important structures that pass through the cavernous sinus. The internal carotid artery passes through, as well as a few of our cranial nerves. So first we'll look at the internal carotid artery. Again, remember, this is like a blood-filled space in the brain. The internal carotid artery, you can see right here. It's kind of coming above the sinus here, and you can see it curving into the sinus, right? So these are the internal carotid arteries. The abducent nerve, cranial nerve 6, also passes through. It literally like crosses over the internal carotid artery. So if you look right there underneath it, you can see, let me change colors. Right here, you see that little yellow dot? That's the abducent nerve. It's kind of coming in from the side like this, and it's crossing over the internal carotid artery. There are also 4 other cranial nerves, or 3 cranial nerves, but there's 2 divisions of 5, so like 4 nerves that pass along the lateral walls of the cavernous sinus. That's cranial nerve 3, the oculomotor nerve. You can see that up here. So from the top to the bottom, it's 3, 4, and then 5-1 and 5-2. So oculomotor up top, the trochlear nerve passes just underneath it. It's really small. And then 5-1 and 5-2. So the ophthalmic, which is 5-1, V1, and maxillary, which is V2. So like I could show you over here. Oops, there's 3, 4, 5-1, and 5-2. Now those just pass along the lateral walls. The abducent nerve or cranial nerve 6, it kind of comes in and crosses over the internal carotid artery. So like if you were looking at it from the side, you would see like your internal carotid artery, and the cranial nerve 6, you would see like kind of coming in and passing over it. Whereas the others you would see just kind of coming straight along the sides. You'd see like 3, 4, and then 5-1, 5-2, just coming straight like that. The cerebral veins and the dural venous sinuses can be occluded, right, like blocked. Specifically, if we look at the cavernous sinus, it's referred to as cavernous sinus thrombosis when the cavernous sinus gets occluded with some sort of a thrombus. Typically, this happens, typically this is septic, right? And there's some thrombophlebitis. So there's some sort of an infection that causes a clot to form, and that makes its way back to the cavernous sinus and occludes it. This can be, it's rare, but it's life-threatening. So it's a very serious thing that can happen when patients have some sort of facial infection. So it can be an infection of the eye, like an ophthalmic infection. It can be, so ophthalmic. It can be sinusitis, right? Some sort of a facial infection can lead to septic cavernous sinus thrombosis. And the reason that this can happen is that typically the blood from these areas, from like the medial border of the eye, so typically blood from the medial border of the eye, the nose, the lips, typically drains down. So all of that blood is typically draining down here through the facial vein. The facial vein is down here. So typically that's all draining downward, but it's possible that it can drain back through the ophthalmic vein, which you see right here, and the ophthalmic vein drains back towards the cavernous sinus. So it's possible when there's an infection in these areas that, that it's going to go back towards the cavernous sinus. And some infectious states are thrombotic, right? When there's an infection present, the blood is more likely to form thrombosis. So again, that can get pushed back and up into the cavernous sinus, and then it results in thrombophlebitis in the cavernous sinus. So again, pieces of infected thrombus can extend superiorly, right, up from the facial vein or ophthalmic veins, causing thrombophlebitis in the cavernous sinus, which again can be fatal. So this is a medical emergency. Signs of this are so like headache, severe headache, vision changes. You can see periorbital swelling. So that is important to keep in mind if somebody has some sort of serious ophthalmic or sinus infection and then starts to present with, you know, periorbital swelling and really severe headaches, double vision, right, other eye vision type symptoms. It's important to keep in mind that this is a possibility. So there is a connection between the venous blood flow in the vertebrae or in the vertebral canal and the blood flow in the dural sinuses, dural venous sinuses. So it's possible that infection or tumor cells can spread through the vertebrae and then up into these dural venous sinuses. Now, the blood that's going into these vertebrae is coming from the thorax, the abdomen, the pelvis. So infection or tumors that are present in these areas can actually get pushed up through the vertebrae, right? We know that tumors, cancer in those areas can spread to the spine, but it can actually get pushed up into the dural sinuses as well. So this is why. The internal vertebral venous plexus, right? That's like all these little veins in here and in here. Those are the internal vertebral venous plexuses. Those connect to the occipital sinus, right? Which you can see the occipital sinus right down here, which goes up to the confluence of sinuses, which really connects to everything else. But these vertebral plexus, the vertebral plexus connects to this occipital sinus. It also connects to the basilar venous plexus, which you see over here. Now, the internal vertebral plexus, again, is connected to veins in the thorax, the abdomen, the pelvis. So if the veins in these areas are compressed, it can actually force blood from these veins, right, from these regions back into the vertebral plexus. Well, that blood can get pushed back up into the brain, right, like up into this occipital sinus. So compression of these veins happens during things like coughing, right, or straining to lift something, straining while defecating. Anything that really tightens the pressure can compress these veins, and that can, push blood back. So if there's sepsis or if there's some sort of infection present in the area, that can be carried back through the spine and then up into the brain. Or metastasis, again, so if there's cancer in these regions, which that's a pretty broad area, right? The thorax, the abdomen, the pelvis, that's a lot of different cancers that can be present. But cancers in this region can also metastasize or make their way back up into the dural sinuses via this route. So cancer cells can metastasize into the vertebrae. We talked about how that's really common for cancers to metastasize into the vertebrae, and then they can also metastasize into the brain. And then again, pus or infection can spread into vertebrae and the brain via this venous route. We talked a little bit about fractures of the cranial base previously when we talked about like CSF otorrhea or rhinorrhea, right, when the CSF starts leaking out of the orifices. This is in relation to the cavernous sinuses. So this is fractures of the cranial base, specifically here near this sphenoid bone. The problem with fractures of the cranial base here is that, remember, the internal carotid artery is going through this region. The internal carotid artery is bringing a lot of blood into the brain. It's really important. And it's going very delicately, if you will, through the cavernous sinus. So when we fracture the cranial base here by the cavernous sinuses, it's possible that we can tear the internal carotid artery. This is problematic for numerous reasons. One, you're interrupting blood flow to the brain, but you have blood flow, from the vertebral arteries and from the other side, but you're also creating an arteriovenous fistula in the cavernous sinus, meaning you're creating a connection between the artery and the vein, which that shouldn't be the case, obviously, because the artery here is delivering this oxygen-rich blood, right? And remember, it's delivering blood at a relatively high pressure, much higher than in the venous system. And then you have all of the venous blood, right, that's present in the sinus. So when you tear the internal carotid artery, now the internal carotid artery is dumping blood into this venous sinus. Now this is problematic. This brings a huge amount of blood at a relatively high pressure and dumps it into this cavernous sinus. So blood rushes into the sinus and it enlarges it, right? And all of a sudden we've got a ton of blood in there, and every time the heart beats, more blood gets pushed into this cavernous sinus. This creates back pressure, right? It can't drain fast enough. So there's back pressure, and all of the vessels that are leading into the cavernous sinus are now getting pushed back. This happens a lot with the ophthalmic veins. So if you look down here, you can see this is the cavernous sinus right here, right? And you can see the ophthalmic veins. Remember we said that the blood from like the medial border of the eyes and the nose can drain back into the cavernous sinus. So here you see the ophthalmic vein leading back to the cavernous sinus. Well, if there's a ton of back pressure here in the cavernous sinus, right, it's going to be pushing blood back into the ophthalmic vein, and the ophthalmic vein is not going to be able to drain anymore. Instead of draining blood, it's actually going to be accepting extra blood. So the result is that there's a ton of blood building up back behind the eyes. Signs of a tear or an arteriovenous fistula in the cavernous sinus are exophthalmos. Exophthalmos is just bulging eyes. Think like exiting ophthalmic eyes, right? So the eyes are bulging out of the head. Now, because this is directly related to arterial blood dumping into the cavernous sinuses, every time the heart beats, right? So you can measure the pulse, and every time, you know, the heart contracts, more blood gets pushed in, so it's pulsating exophthalmos. You'll see the eyes pulse or push out more every time the heart beats, because that increases the blood and increases the pressure pushing out. So pulsating exophthalmos, chemosis. Chemosis is engorged conjunctiva. So if you look up here, the conjunctiva, this like pink lining in the eye, get incredibly engorged. And so you can see, you know, on both sides, this just, the eyes are protruding, but the conjunctiva are so engorged, they're just like swelling over the eyes. This starts as being a unilateral problem. Typically, you know, there's some sort of a fracture. Typically, it doesn't tear both of the internal carotid arteries, it'll tear one of them. So it starts as being a unilateral problem, but that progresses to bilateral. And the reason for that is, remember, these, the cavernous sinuses are connected to each other. Remember, they're intercavernous sinuses. There are the little vessels, right, that connect or interconnect the two cavernous sinuses. So if there's a bunch of blood building up in this one over here, it's going to go through the intercavernous sinus and it's going to go build up over here as well. So that's a good kind of sign. You know, it starts on one side and then the other side starts to progress as well. Remember that the internal carotid artery is not the only structure that's going through the cavernous sinus. There are quite a few cranial nerves that are in that area as well. So there can be injury to cranial nerve 3, 4, 5, 1 and 2, and 6. They're all in proximity, right? We looked at all of them right here passing through the cavernous sinus. So if there's a bunch of blood buildup in there, those are going to be getting compressed. And you can start to see other signs and symptoms related to compression of those cranial nerves. There are headaches that can originate from the dura. Remember, we said that the dura is innervated. It has sensory fibers that are carried either by the cervical nerves or by cranial nerve 5, most likely or most commonly V1, the ophthalmic nerve. But there are sensory fibers that come from the dura, and the dura is sensitive to pain, and we perceive that pain as a headache. This is typically referred pain. It's referred to like the cutaneous regions, right? So you feel pain like around your head here, or mucosal regions. You could feel pain in your eyes, for example. But the dura is sensitive. What typically causes this pain is distension of the scalp or meningeal vessels. And this is thought to stimulate the pain fibers. Dural headaches are common post-lumbar puncture. That's the severe headache that patients get post-lumbar puncture. And the reason for this is after a lumbar puncture, when you removed some of the cerebral spinal fluid, remember the CSF keeps the brain like buoyant. It keeps the brain floating in the cranium. So when you remove some of that cerebral spinal fluid, the brain can sag in the cranium, right? It kind of sits a little lower in the cranium, and that pulls on the dura mater. Pulling on the dura mater stimulates those pain fibers, and that produces the headache that's associated with a lumbar puncture. This is why we tell patients to keep their head down post lumbar puncture, right? So like, I don't mean down like that, that would make it worse. I mean like laying down. Because then gravity is helping you, right? If you're upright like this, then the CSF is getting pulled down and the brain can sag. But if you're if you're supine, right? If you're laying down, then the CSF is more horizontal and the brain isn't sagging as much, and that prevents that dural headache. Okay, so we're going to look at different head injuries and the different types of bleeds or hemorrhages that they can cause in the brain. All different intracranial hemorrhages can occur just depending on where the vessel is that breaks and where the blood is accumulating, right? It can accumulate outside of the dura mater. It can accumulate deep to the dura mater. It can accumulate deep to the arachnoid mater. And this gives us all different types of hemorrhages. Also, there's a difference between an arterial hemorrhage and a venous hemorrhage. Arteries obviously have more pressure, so they tend to bleed faster. So we'll start by looking at an extradural hemorrhage, or it's also called an epidural hemorrhage because the bleed is epidural, right? Epidural hematoma. The bleed is occurring outside of the dura mater, so it's literally like right up upon the skull or the calvaria. These epidural hemorrhages tend to be arterial in nature. And the reason for that is that they're all of the arteries that feed the dura mater. Remember, we talked about the middle meningeal artery. We said there's the external carotid artery, and then you guys saw how the middle meningeal artery came up and then split, right, to go towards the frontal region, the parietal region. Well, that middle meningeal artery is really close, as well as the branches of it. Those branches in the middle meningeal artery are really superficial. They're located outside of the dura mater itself. So when there's a skull fracture, those are the arteries that are most likely to tear because they're right by the surface. So some sort of a blow to the head tears a meningeal artery or one of the branches of the meningeal arteries, and blood accumulates between the dura mater and the skull itself, right? Because those vessels are located outside of the dura mater. You can see that here. What you're looking at, the really white areas, the skull itself, right? The calvaria. And then this gray in the middle is the actual like brain. And then this black, right? The like really, really dark area, that's the dura mater. So you can see here, this is where the bleed is. This is where the epidural hematoma is. You can see that the blood is right up against the bone, right? You don't see, there's not a layer of dark dura mater on top of it, right? The blood is like right there. It's outside the periosteal layer of the dura and the meningeal layer of the dura. Symptoms include a brief concussion or loss of consciousness, and then a lucid interval. So there's a brief loss of consciousness when the injury first occurs, and then a period of time where the patient seems lucid. They seem like they're doing okay. But as blood accumulates, and this happens relatively rapidly because this is arterial, as blood accumulates and more pressure on the brain occurs, drowsiness, the patient starts to feel really drowsy and then slips into a coma. This has to be evacuated. You need to evacuate the blood, as in drain the blood, and then occlude the torn vessel. You can also see it here in pink. You see the actual brain, and then in blue, that's the subdural area, right, where the dural sinuses, the dural venous sinuses. And then in white, you see the dura mater, and then on the other side of it, you see the blood right up against the calvaria, the bone itself. Again, these are typically arterial, so they're relatively fast. A dural border hematoma or a subdural hematoma occurs when the bleed is beneath the dura mater, right? Subdural, so it's underneath or deep to the dura mater. A subdural hematoma occurs when there's some sort of a blow to the head, or when the head jerks really fast, like whiplash, right? When the head flings back and forth like that, it like yanks on the meninges, and that can tear a vein as it's heading towards one of the sinuses. These bleed, right? A vein is opened, but because these are typically venous, there's less pressure and the blood leaks more slowly. So over time, blood tends to accumulate, right, creating a space between the dura mater and the arachnoid mater. Normally, the arachnoid mater is pushed out up against the dura mater, right? Because remember, the CSF pushes the arachnoid mater out and it's up against the dura mater. But as the blood accumulates in that area, right, it starts to separate the two. So typically, what you would see here, so this over here is epidural, right? That's what we just looked at on the last slide. This is what we're talking about right now, a subdural hematoma. And if you look over here, you can see, right, the subdural hematoma is right here, right here. Notice you can see the dura. Remember, the dura is this like black line right here. That black line is still present, separating the bleed from the bone. The bleed is inside the dura mater. It's subdural. So like what you can see here is this is the superior sagittal sinus, right? That's the big sinus that's draining blood down that longitudinal fissure. And there's a vein, right? There's a vein right here that's leading into it. There shouldn't be this big space right here where all this blue is. It should be like this over here. The arachnoid mater should be pushed up against the dura mater, and the space that's present should just be the subarachnoid space with CSF. But because of this torn vein that's present right here, blood starts to leak out, right? And it starts to create this space, and you can see that the brain gets compressed, right? It gets pushed in as the blood accumulates. This can take weeks to occur, and the precipitating event might be relatively trivial, right? With this epidural hematoma, there was some sort of a really strong blow to the head, and there was a skull fracture that, tore this meningeal artery, and it was this big trauma, and it was a really rapidly occurring event. But with the subdural hematoma, it doesn't always have to be that way. It could be a large precipitating event. There could be a car accident, with really bad whiplash, for example, or like a strong blow to the head. But it could also be a relatively trivial event that, has a little tear that occurs and the blood slowly accumulates. This is what happens, or what can happen with shaken baby syndrome. With shaken baby syndrome, as the skull or as the brain bounces back and forth, it pulls at the meninges, and it is possible to tear one of those veins when that happens. A subarachnoid hemorrhage is a bleed underneath the arachnoid mater, and the blood typically escapes into the subarachnoid space, which the subarachnoid space is typically where we would have cerebrospinal fluid flowing, right, in the space that surrounds the brain, but instead blood starts to accumulate in that area instead. Subarachnoid hemorrhages are typically the result of a ruptured aneurysm. It is possible that there's head trauma that causes this, but just most frequently, it's caused by a ruptured aneurysm. There are blood vessels, right, that are going all around the outside of the brain to feed the brain, and that's what you see here in this picture. You see the internal carotid artery, going up and into the brain, and you see the vertebral veins coming up here, right, going into the basilar brain and then going in. So these vessels are going all around the outside of the brain, right, to bring blood to the brain. And it's possible that an aneurysm can develop. An aneurysm is what you see here, right, like a weak spot in the vessel wall causes a bulge. Eventually, that bulge gets really, really weak, and if there's a period of higher blood pressure, it can burst or rupture. Then blood starts to leak out and blood starts to accumulate in the subarachnoid space. This results in meningeal irritation, right? The meninges don't want that blood there. They want CSF flowing nicely through that area. So this irritates the meninges. We know that the meninges have sensory fibers. They have pain fibers. They can feel pain. So, and that is noticed as a headache, or referred pain gives like the feeling of a really severe headache. So these are associated with severe headaches and then eventual loss of consciousness.